Hi, everybody. Thanks so much for coming to the April Community Practice meeting. We're going to get started in just one sec. Hi, Ruth.
Hi.
Thanks so much for coming. We're just going to get started in a minute or so. Just updating, making one quick change to our slides. How are things in Saskatchewan?
Oh, are you talking to me?
Yes.
I'm in Manitoba.
Oh, I'm so sorry.
But
I got the
that's
province
okay.
totally wrong.
But we have snow this morning, so that's great.
Oh, wow.
Not much.
Yeah.
I'm sure
Yeah.
it'll melt tomorrow.
Yeah, we already have like spring bulbs coming up here in Toronto. So
Nice.
and while we are waiting, if you folks would like to click on, or rather use the QR code to do our Slido poll, and we want to ask the group while we're there waiting, do you have any ideas for a community practice special interest group? Because it was brought up to us when we had asked for feedback that, maybe there might be like people who are all physios want to get together and form a special interest group, or let's say if the researchers want to form a special interest group. So if you have any ideas, please scan the QR code and let us know what you think. And we're gonna just wait another 2 minutes and then we're gonna get started. Just give me 1 second. I'm just gonna bring the Slido to my other computer, so I'll be able to run it a little more effectively. And then let me just get this back up here. Hi, Erin. Great to see you. Thanks for joining.
Hi.
Hi, Min. We're going to start in a minute. And in the meantime, we have a poll while you wait. If you have any ideas for a special interest group within the community of practice, please feel free to let us know.
Yes, I'm monitoring the Slido. I'm not seeing any answers coming in just yet, which could be because people don't have anything that comes to mind. But if there are, we would, definitely love to hear if this is something, because we are always looking at ways to try new things in our community of practice and make sure it's accessible and most interesting to everyone in the community.
Okay, McKyla, I think we should start, if that's all right.
Absolutely.
Okay, so this is our agenda. The first thing that we're going to be doing is we're going to be having a talk from Tharshini and Mark on an AI agent for triaging patients with acute concussion. And then in response to the feedback that we got from the community practice about like wanting to know what remote monitoring devices there are out there for use or potential use with Telerehab in Canada, we had done an environmental scan and grid literature search, so we're presenting the results there. Next slide. Okay. So just a reminder for those of you who might be joining, because someone forwarded you a link, please come join us at the Canadian Telerehab Community Practice. We have meetings once every 3 months, and they're always great speakers. And if you use the QR code there, it will take you to the sign up form. And then below is our current working group. We also have, sorry, next slide, 2 announcements from Jennifer O'Neill, who has been a very active member of our community of practice. So first, she wants to let you know that there is a 3-day virtual care and rehabilitation conference in the Canadian context called Beyond Boundaries, Telerehabilitation, the Virtual Care Revolution. I just signed up today. It's $60, but it's 3 days worth of talks. And they have some great speakers. McKyla and I are going to be presenting a little something as well on Monday. And then the second thing she want to let us know about is that she's actively recruiting for co-creation of telerehabilitation intervention for people with ABI study. So if you want to use the QR code over here on the right side of your screen to participate, that would be really great. So, and also if you have any like patients or people that you work with who fit into category 1 or 3, please do forward this on to them as well. Okay, and if there's anybody else who have announcements like that you want us to include in the future for the COP, like let's say you have research studies you're trying to recruit for related to telerehab or some kind of cool event you're organizing, please let McKyla and I know because we would love to include that in our meetings. So now we're going to go on to the first talk. And our speakers are Tharshini, who is the manager of the Hall Ellis Concussion Research Clinic, and she has over 30 years experience in brain injury. She is really focused on knowledge translation and bridging the gap between research and practical applications in patient care. She oversees both clinical care and research activity at the Hall Ellis Concussion Clinic since it has started in 2015. And our second speaker, Mark, I don't think he needs any introductions, but anyways, I'll just take a go at it.
That's okay. You don't need to. They can read it.
Okay. Oh, I think most people know who Mark is, but he's basically my boss. He's the program medical director and physiatrist in chief at Toronto Rehab, and I think he's been the greatest thing since sliced bread for brain injury and stroke rehabilitation research in Canada. He's done so much. You can read his bio. I can't even summarize it. But without further ado, we are going to go now to their talk. So Tharshini, if you wouldn't mind sharing the slides, we're going to stop sharing and give you the floor. There's also somebody who has a lot of hissing noise in the background. I'm not sure where that's coming from, but if you happen to have some hissing in your background, if you could mute yourself, that'd be greatly appreciated.
Okay, thank you very much, Meiqi, for that intro. And I hope everyone can see the screen that I'm sharing. Hello, everyone. Thank you for having us today. My name is Tharshini Chandra. I would like to, I'm here with Dr. Bayley. We'd like to take you through the development of the acute concussion triaging agent, or AVATAR, that is called ACT-A, that we at Hall Ellis Concussion Clinic have developed or worked together with Dr. Shiroz Khan and Alia Bayley in Kite Research to create. The following are Dr. Bayley's disclosures. I have no conflicts or commercial benefits to disclose. Our objective today is to give you some context in which this tool was developed, take you through a brief demonstration of the AVATAR itself, and then discuss the findings from our pilot feasibility study that we did amongst our patients. And at the end, we're hoping to spark some discussion and debate on the risks and benefits of this approach. As you all know, concussion is the highest frequency of TBI, with about 450,000 concussions occurring each year in Canada. There are no gold standards for diagnostic tests. Physicians rely entirely on patient self-reporting symptoms, and no accurate methods are also available to predict recovery. There appears to be a bit of a gap in regular care and monitoring for concussion patients. In terms of research, most research has been done with athletes or adolescents, but not in the general population. And from the data that has been collected in the athletic population, it is known that the athletes recover, about 85% of the cohort recovers within 2 to 3 weeks. And about 15% still have protracted recovery. The Hall Ellis Concussion and Research Clinic was established to provide acute, rapid access concussion care to the general population. While we do this, we also collect dozens of variables to better understand who gets better and who doesn't. We would like to then use this innovative platform to use innovative assessments and provide timely education to our patients as they come in through the clinic. We then also use the data that we collect to develop specific care pathways for groups that are at high risks for prolonged recovery. So some of the research questions that we have explored in our clinic are: who recovers? Are there sex differences? Does age matter? What is the underlying pathophysiology? What does the recovery of individual concussion symptoms and signs look like? And how can we enhance recovery from concussion in this population? Since 2016, we have partnered with 8 different emergency departments here in Toronto, and referrals come from these emergency departments to our clinic. We see all patients within 7 days of their injury. Sometimes we see them as early as 24 to 48 hours post-injury. That's how acutely we see them. And we follow them clinically and collect research data for up to 52 weeks post-injury. These are our inclusion criteria. Just briefly, I will not go through all of them, but this is just to ensure that all patients who come through our clinic have a true concussion diagnosis of concussion. And the diagnosis of concussion is also confirmed by our clinic physicians upon their first visit. Please note that we do not see compensation-related injuries, such as workplace or motor vehicle-related injuries. We do have specialty clinics within UHN that provide care for this population, and so we just triage these patients to that clinic. Some clinic stats to show the volumes that come through our clinic. We could receive anywhere from 50 to 60 new referrals a month. We see about anywhere from 8 to 10 new patients a week, and our enrollment in our study is about 60 to 70%, which is pretty good. Kudos to our research assistants. This is just who do we care for, who are our patients. The average age is about 33.4 years of age. Most of our patients are females. About 60% of our patients are females. Our median education is bachelor's. Income is about 40 to 60K. The 3 most common pre-existing conditions amongst our folks are anxiety, depression, and migraine. And most of our folks are either employed or are students. In terms of the mechanism of injury that we see and the distribution of it, the most frequent injury is due to fall or falling or flying objects. The next most frequent is sports-related or exercise-related injuries. And then the next 2 common are either they hit their head on an object or fell off a bicycle and hit their head. From week 1 to 8, research data is collected. At weeks 1, 2, 4, 6, and 8, patients have physician assessments, and self-reported symptoms are also collected using the SCAT self-reported symptom section. Patients are seen by the physicians until they're deemed recovered, which means that if they are recovered before the 8 weeks is up, they are conditionally discharged. And what recovery means is that they are asymptomatic or back to pre-injury baseline level of symptom and functioning. And if they are conditionally discharged before week 8, we finally do see them for one last visit at week 8. This is just to make sure that, when they do go back to their normal activities or return back to their work and sports related activities, that they are still symptom free and are recovered at week 8. Physicians are provided with a standardized manner of rating recovery. This guide is adapted from the International Concussion Statement, where a scale of 1 to 6 is assigned for 3 domains. And these domains are physical, cognitive, and sensory domains of functioning, for a total score out of 18. So if a score of 1 is indicated, it means there's a complete loss of daily functioning in that domain. And if a 6 is given, it's taken as the point of recovery. So who recovers in the general population? I'm going to just quickly highlight some of our findings. And you can see these in the publication in the Frontiers in Neurology as well. This is our publication that has more in-depth results. But just to highlight a few things, we found that only 18% of our cohort recovered by about week 8. 26% of this cohort were unrecovered by symptoms. And most of our folks, about 56%, recovered between weeks 4 and week 8 post-injury. Similar to previously published athletic concussion cohorts, females are more likely to experience prolonged recovery in our cohort as well compared to males. And also similar to previously published athletic concussion cohorts, those with high acute symptom burden are more likely to experience prolonged recovery. In order to determine whom we should be targeting for follow-up and close monitoring, we looked at pre-injury factors to determine odds ratio of not being recovered at week 8. And those were females, or increased age of over 36, or a pre-injury history of migraine. Therefore, we may want to focus and prioritize to closely monitor females, those who are 36 years of age or more, and anyone with pre-injury history of migraines. Our results with the general population aligned with the athletic cohort in 2 areas. So females are more likely to experience prolonged recovery compared to males. And the second was that a higher symptom burden acutely is likely to mean prolonged recovery. But contrary to the athletic cohort, what we found was that the past history of migraine headache is more likely to predict prolonged recovery, but not anxiety or depression. And the next one that is different from the athletic population is that the average recovery time in our population takes about 1 to 3 months, whereas in the athletic population it took about 1 to 3 weeks. So why AI? Why, with the large number of people with concussion and with poor access to care and some recognizable predictive factors that we have learned of, what we'd like to see is could we standardize the interview and then deploy it remotely to help triage who should be seen, who should be focused on and monitored closely? Could we use this as an initial screener within a clinic setting to help physicians triage? Would this make the physicians work faster and efficient so that they could care for more patients? We want to acknowledge that this would need to be validated with the clinicians for this to take place eventually. So what we did was our team developed a fully functional web-based version of ACT-A featuring an interactive speaking avatar that processes interview materials. We also built in speech-to-text and interview summarization. Interviews can be conducted with 4 different languages, including French, Mandarin, and Punjabi. We took our ACT-A through rigorous internal testing before patients were exposed to it. We then piloted it with some of our patients. We collected qualitative feedback. We also collected data using the system usability scale and user engagement scale, short form, in line with established research practices. So what I'll do now is please give me a minute to just switch screen and share the ACT-A and do a little bit of a demonstration for you. And I would like to turn off my video because this does demand a lot of memory, and so I don't want to see any lags on this video. So please hold on while I share my other screen. Okay, is everyone able to see my screen?
Yeah, we
Great.
can see the avatar now.
Very cool. So I will act as a patient while the avatar interviews me, and my apologies in advance if there is a lag, as my laptop is not well equipped to handle this kind of demand. So here we go. And please do let me know if you're not able to hear the avatar.
Welcome to the Hall Ellis Concussion and Research Clinic. My name is Act A. I'll ask you some questions related to you and your injury. Let's get started. What name did the study team give you to protect your identity?
225. 225.
How old are you?
45.
What's your biological sex at birth?
Female.
What was the date of your injury?
14th of April 2026.
How did your injury occur?
I fell off a bicycle and hit my head.
What is the last thing you remember from before your injury?
Riding down south on Bathurst Street.
What is the first thing you remember from after your injury?
Being on the ground.
Did you lose consciousness?
Not that I recall.
Did you feel dazed or confused at the time of your injury?
No, but I think I was in shock.
When your concussion occurred, did you have any other injuries to your body, not related to the head or neck area, for example, your knees or back?
No. No. No.
Before this injury, had you ever been diagnosed with a concussion by a medical professional?
Yes.
How many times?
Just once.
When was the most recent diagnosed concussion before this new injury?
In 2022.
How long did it take you to recover or get back to normal after your previous concussions?
About a month.
Before this injury, had you ever injured your head or neck but were not diagnosed with a concussion?
Yes.
How many times?
Once. Once.
When was the most recent incident before this new injury?
2020. 2020.
How long did it take you to recover or get back to normal after those injuries?
I would say about 2 weeks. Okay. That was the end of our demonstration. I'm just going to go back to my slides here. Oh, shoot, my apologies. Okay, so we piloted this ACTE with about 13 individuals, and we have complete follow-up data for about 10 patients. We have the system
Tharshini, I think
usability.
your screen is not sharing. If you were, sorry to interrupt. Your slides didn't appear yet.
My apologies, Mark. Just one
Yep.
second. I'm going
No
to
worries.
share it. Thanks for pointing that out.
Yeah, we can see them now. Thanks.
Wonderful. Okay, thank you. So as I was saying, we piloted the ACT with 13 individuals in our clinic, and we have data for about 10, complete data for about 10 individuals. We have system usability scale scores of about 80 or higher, which is great. That indicates good satisfaction. The only exception is that one of our patients provided a 72.5 score. Across the 10 participants, some common themes and feedback that we received was improving the realism and human-like interactions of the avatar. Some patients also pointed out that using large button sizes for accessibility would be great, and they would like us to consider for change in the background of the avatar. That background that you saw is our clinic exam room, just for context. And then also patients suggested that we add in more customization of pacing for the interview. Currently, as you may have noticed, the patient actually has control over the pacing. So I click when I'm satisfied with my response, and then the next question comes up. And then the other feedback that we received was that that we should be allowing the user to review the summary of the accuracy. And this is all feedback that we hope to address in our next version of the avatar. And so what is next for our avatar? We would like to expand the question set. So currently we're in the process of reviewing the expanded set of questions with our physicians to get their input on what's appropriate for the physicians to ask versus what can be obtained via the avatar. And then we'd also like to then transition this to a cloud-based tool that can be used externally. And then we're also looking at verbal tone analysis and facial analysis so that we'll be able to detect emotions and pain. And that's what we're hoping for this project next. I would like to acknowledge our clinical and research staff who contributed to this work, and then also open it up to you for questions. And we would like to hear your thoughts and possibly also on potential risks and benefits of using this approach and any questions you may have.
Thanks.
Thank you so much, Tharshini and Mark, for your great presentation on the concussion interview avatar. We really appreciate you taking the time to present on this topic, because in previous community practice meetings we had discussed about use of AI in conjunction with telerehab, and I think what you're showing is a really interesting application of AI to help clinician workflows potentially in telerehabilitation. I want to open it up to questions from the group before I start asking any questions. Or if people want to have comments in response to Tharshini's question that was posted.
One of the things I will just comment that it was interesting that the person wanted the avatar to be a bit more human, and our experts in AI have actually told us that it's kind of spooky if the person looks too human, and that most humans actually prefer an avatar. So that was an interesting observation. Just to comment on that. Yeah.
Angie?
I'll start us off because I know there's lots of questions, and I just thought this was fantastic. Hi, Tharshini and Mark. I was just really, really interested and impressed. I think I loved comment perhaps that the avatar allows the user 2 ways to really think about their responses, because I think those questions can be hard. Like, how long ago was my neck injury? 5 years? How long? And I love that I could probably take a moment to reflect on that before submitting, and then review to make sure I was giving you the correct answer. Is that correct?
Yes, that's correct. Tharshini was hitting submit every time once the answer was to their satisfaction, right, Tharshini?
That's correct. So I was driving the process, Angie. So if I wasn't ready or if I wanted to change the answer, I could technically keep speaking and then submit.
Yeah.
And at the end, we're hoping that in the next version, because we've received some feedback from our patients, patients about being able to review the entire report before they submit it, that's something we can definitely work with our team to accommodate. But at the end, we're hoping that it would create a report for our physicians to review, and it'll be a starting point for our physicians to sort of recognize.
Yeah, that was great. Thank you.
I'm going to ask a question then. So, based on your experience so far, what do you anticipate could be the biggest barrier towards integrating avatars in real life rehab practice settings? Like, is it going to be workflow, clinician trust, patient engagement? And also, Mark, I too was imagining that the avatar will look kind of cartoonish. Like I had in my mind Miffy Bunny Doctor. I don't know if anybody knows who Miffy Bunny is. That's what I was thinking, like something really cute that's gonna ask me questions. So yeah.
We could do an RCT of generating a different avatar for each different user and see which one was preferred.
Yeah.
I'll let Tharshini answer that because she's had a lot of conversations or some conversations with our physicians who are going to be the receivers of these reports. So
I think physicians' reluctance to use this might be one of the barriers. We feel that even amongst our group, most physicians are very excited because they're just so happy that this is something that will really make the workflow easier and efficient for them. But we have a number of individuals who feel that they, first of all, don't like the appearance of it. They feel that the sound and the audio is just so non-human-like, and they don't feel that it's something that the patients will receive well. And they're not quite sure how much time it'll save for them or how useful this will be. And we're hoping to make it as efficient as possible and provide them with as much information as possible so they do see the benefits of it in the end. But that's sort of the only one that I have noticed. In terms of patients have been quite open to it. We didn't get any sort of negative reaction or reluctance to use it.
Thank you so much for that response. And Erin?
Yeah, hi, can you hear me okay?
Yep.
Okay, perfect. Sorry, I'm driving, so I never know if it goes through clearly. I'm just thinking about sometimes the concussion patients I see have like just trouble with auditory processing and like maybe some like noise overstimulation. Does it give patients the opportunity to write their responses as well if for some reason that is an issue for them?
to date, it's been all voice activated, right, Tharshini?
That's right, Mark. We haven't really considered it, but that's a very good point that we may want to look into whether the patients can type the response instead of speaking into it. And then we can certainly turn off the screen if the patients don't want to really look at the bright screen, if they have any light sensitivity. But the writing piece is something that we would definitely consider. Thank you for that.
It would also be good just from a communication accessibility as well. If you get a client that comes in who can't speak or has an aphasia, then it gives them the opportunity to potentially write their responses if that's a stronger skill for them. So I guess you could look at it in numerous ways, but it might just improve the accessibility of the application. But I really love it.
Definitely. Thank you.
Yeah,
Thank you for that.
it might not. Yeah, I mean, the good thing was that you may not have been able to appreciate it. Is that the answers are typed out in front of the person. So theoretically, if we allowed them the ability to look at what they said and then edit it, that might be a good compromise, right? That they can just say it and then, oh, the voice transcription didn't get it, and then we can correct it if needed.
Right. Yeah, for sure.
Linda?
Hi there. I don't have a lot of familiarity with AI assisted programs, and you've mentioned a couple of times about assisting in workflow. Can you maybe explain a little bit more about what that means?
Sure. Maybe I can comment on it. AI is now, a lot of family doctors now have AI scribes. We have some people who have an AI scribe who are tuning into this meeting, and you might see their name as AI. And I think what it is really using AI to do routine functions like transcribing interviews and actually putting them in a format that's digestible for the person. So fitting it into workflow, the idea would be that the person could be referred to our clinic. They could administer the tool remotely from their home at whenever they want. And by the time they arrive, we already have a history of their symptoms, and we have some scores that might have been administered. And so the physician doesn't have to repeat every single question. And the idea we're working on is the hierarchy of a question like a physician or a therapist might ask, like, tell me about your headache. When does it come on? What makes it worse? What makes it better? Where does it located? So all the things that you would probably do. And so the idea is, rather than doing a repetitive history, you'd have the confidence that the artificial intelligence has already gone through those logistics that a physician or a assessor like a therapist might have already gone through. So that's how AI is kind of deployed. It's really doing the thinking as you set it out. Does that help explain, Linda?
Yes, that helps a lot. And I mean, that's one of the common things that you hear from patients. Often every time they see a new practitioner, it's like, don't you guys talk to each other? I've told you all of this before. So if anything would help with those kind of comments, that would be fantastic. Interesting. Thank you.
Thank you so much, Linda, for that question. Just in the interest of time, because I'm sure other people have more things that they want to ask Tharshini and Mark about, we also have a second presentation actually for this April Community of Practice meeting, which is to follow up on the thread that we had from a previous meeting where people were interested in what remote monitoring devices are currently commercially available in Canada that could be used in conjunction with Telerehab. So McKyla and I are going to present on the literature search that was done to investigate that question. I'm going to just get this on my screen right now and then we'll share. And while it's McKyla and I are talking, it's actually Kiran who is here today who did the search. She is a nurse by background, and she also has lots of lived experience as a carer for family members with rehabilitation needs. So really, really want to thank Kiran for her contribution. Thank you. So in our presentation, we're going to discuss times that you might consider using a great literature search to answer a clinical question, and then we're going to review the common commercially available remote monitoring devices, including their strengths, limitations, and how we might be able to use them for telerehab. In terms of great literature search, I'm going to just briefly explain what it is because not everybody is familiar with it. So we all know about like a literature search, right? Like when we're looking in the scientific literature to find some articles, whereas great literature is stuff that's outside of traditional academic publishing, like white papers, government documents, industry reports, things like that. And it provides, quote unquote, on the ground data that's not necessarily published in academic journals. And you might want to look at it because it can help you find emerging research topics, specialized data that hasn't been published yet, or local information specific to your context. So we did internet search for our great literature search using Google. And we specifically wanted to identify commercially available consumer ready remote wearable monitoring devices that are available in Canada. These are the search terms that we use, and then we looked at manufacturer websites, and Kiran also directly corresponded with some manufacturers to clarify the device features. And a disclaimer, so we don't have any financial relationships with any devices listed, of course. Nobody wants to pay us anything, like just volunteering our time here. And the brand names are listed only to help you with access. If we just say like a smartwatch, like then you would have to go and like figure out what it is yourself, and you wouldn't be able to actually like tell your patients or tell your colleagues, oh yeah, by the way, this smartwatch does that. So that's the only reason we have brand names, okay? So these are the commercially available remote monitoring wearable devices that we found. And we're going to take you through each one of these. The TELUS Health Medical Alert, wearable necklace and belt clip, Lifelines on the go wearable necklace, Apple Watch, and Google Pixel Watch. So the TELUS Health Medical Alert, this is mainly used as a fall detection device. And I think that's what the majority of consumers out there in Canada are purchasing it for. But you can actually use it for telerehab in another way, because if it's linked with a caregiver app that, you can actually, like a patient can give their physio or their other rehab provider access to, you can get steps, like how many steps they have done in a particular time period, which then allows you to monitor their physical activity. This particular device also offers location tracking. So, I guess theoretically, if you're interested in whether they're leaving their home or not, that's another data point that you could potentially get. It uses like cellular coverage, so it doesn't need to have Wi-Fi where people are going. And they also have, because it's mainly used as a false detection device, 24-hour access to emergency support, and there's two-way calling as well. It is not cheap. It's about $55 per month plus tax if you're a TELUS member, and $65 per month plus tax if you're a non-TELUS or Kudo customer. And their false detection, it's like, which is their primary function, works in this way. So like if there's an alert, let's say somebody presses the button, or if the fall detection feature detects a fall, then the two-way pendant, the two-way speaker on the pendant that the patient is wearing is gonna like go ring ring, and then there will be like an assistant on the line will be like, oh, hello, Mr. So-and-so, what's going on? And if it's a false alarm, they can just cancel the call. Then there can be family and friends that are contacted if either the patient's asking for help, or if they are not able to respond. And then in step 4, emergency services can also be contacted. The second device is a Lifeline on the go mobile personal emergency response service. And this one is just able to track falls detection. Like, I guess if you are working a falls prevention program and you wanted to better understand how many times your patient is actually falling, after they start your program, this will be the device, but it doesn't give anything else. It doesn't give, steps, doesn't give location, doesn't give any other physiological monitoring. And again, it's similarly uses cellular network. The cost is $65 per month. And it works mainly as a false detection device. And again, it's sort of like if so the patient can press the button, or if the false detection algorithm picks up somebody falling, then they'll connect with the Lifeline of Response Associate, who will then send help. And now I'm going to pass it on to McKyla, who's going to talk about the Apple Watch.
Thanks so much, Meiqi. And I agree. It was actually so interesting getting to learn about some of these devices, because they're things that I've heard of and seen, but didn't realize all of the features that were helpful for remote monitoring. And I think the watches were a really good example. So we've got a couple different watches we wanted to make you aware of, and we picked one from the Apple sphere and one from the Google sphere, recognizing that many people are either use Android or they use Apple. So for Apple Watch, so this one, like sometimes people think about it for some of the health data monitoring, but keep in mind that it does have a fall detection feature, and how that works is using motion sensors and impact. So it does need to be a relatively hard fall for it to be able to detect. It could also be triggered if the side button is pressed. And it does have location tracking. It will auto call 911 if there's no kind of signals from the watch after 1 minute, but there's not like a monitoring center for it. It would just be like a straight call to 911. And then there is this location tracking, but it works when If someone's on Wi-Fi, they need to be connected to a network, or if they've got cellular, could be anywhere with signal, but it's picking up on other iPhone devices that are nearby. And so it does need to be, it is compatible only with iPhone. I also just want to let you know that the prices, so we know that the prices may change over time, but it's just to give you a little bit of a ballpark because people may be asking you. But also keep in mind that this is not including cellular plans. This is really just for the device themselves. So we can go to our next slide. And yeah, so look at all these cool health metrics, because I know that a lot of the commercials that I've seen for this will show people taking their ECGs, checking their oxygen levels. Of course, we know about the heart rate. But a lot of people I've noticed have been enjoying using it to track like sleep scores. There's kind of heart rhythm notifications. You can also have apps to help you with medications, mindfulness, things like that. So this is a strength of this device, I think, that there is this kind of advanced health tracking. As we said, that there's no device that can directly link to an EMR, but it's relatively easy and user-friendly for tech-savvy people to export the health data. And then once it's exported, the person could share it with their health provider. It can be a little bit complex for someone who's not super tech savvy. We've also heard, and I've heard this feedback too, that because it's got kind of a small screen and the buttons, that may be challenging for some of our patients if they have either fine motor difficulties or difficulty with their vision. But yeah, it's a really nice device and you might just notice that your patients are just wearing this. So it could be nice to be able to just ask them what kind of things they use and be aware of some of the things that they may not even know about, but that that's already built into their device. So we'll go on to the next slide. So yeah, this is just a little bit more background about how a fall is detected. So yeah, I think it's pretty much what we've talked about, but it can make an emergency call. It can also, I didn't mention this, send a text to any emergency contact. So the person can set up their medical ID. That can include location as well as people that should be notified. So that's a really nice feature as well. Okay, so now I think we're on. Okay, and this is the last one for the Apple. It's just showing sort of how the health data will look on the phone and how you could actually export it and give it to any treatment provider manually. So, but hey, not everybody wants to use iPhone, and that's okay. The Google Pixel Watch is another really nice device as well. And it also has a lot of the similar features. So it's also got fall detection using the motion and impact sensors, or if the crown is pressed 5 times. And it also similarly will trigger a call to 911. It doesn't have its own monitoring center. It also has options for Wi-Fi or cellular. It's Android only, but that's nice because we've kind of showed you that whether you use Android or whether you use iPhone, there's some smartwatch that could be used. There's also some links with Fitbit as well, because you may have patients that use Fitbit. There are a few less health metrics compared to the iPhone Apple Watch that I showed you, but it's still pretty darn good in terms of like heart rate and rhythm, ECG, blood oxygen, and sleep and stress. There is very strong fitness and health tracking with the Fitbit integration. So that I think that is a strength. That's probably a little bit more advanced than the Apple Watch. We talked about falls detection, and it can also be a little bit tricky for non-tech users. So yeah, similar strengths and limitations. It also doesn't have the hypertension notification. So if that's something that's important to you, that would maybe sway you more to Apple. We'll go to our next slide. I think this is also, yeah, just showing about the fall detection. So there is an auditory cue, which is kind of helpful, so that in case it was just a false alarm, that the person could cancel. But if it doesn't, it will actually ask you if you want to call emergency services, but it will if you don't respond or cancel. And we'll go to our next slide. So yeah, health data is tracked and synced with Fitbit app. And you can also export the data similarly to what we mentioned. So just to summarize, I think that what we just wanted to show is how you might use gray literature to answer these kind of questions, because you all may have your own questions that where, you know, information that's produced outside of our traditional academic publishing could be super helpful for these kind of, you know, on the ground market research questions that you have to help your patients. So I really appreciate Kiran's search strategy that we showed. So that gives an example of how you could systematically work through gray literature to answer your own questions. And we've showed you some different devices. This list is not exhaustive. Kiran is on the call for questions and can talk about other devices if there's interest, because she did find more than we were able to show in our time. But keep in mind that there's none that have been shown to directly link into EMRs. There is a cost, of course, so we don't want to minimize that. We recognize it these can be cost prohibitive to people, but it's just yet another tool in your rehab toolbox. But do keep in mind that you'll want to check the periodically product information, because there will, as we know, always be technological updates, cost updates, and so on. Okay, so we can stop sharing there. Thanks so much for listening. And we've got some more time, so we can take your questions about these devices. We can also have just roundtable discussion about anything else that's on your minds or questions from part one, if more have come to light. I also just want to alert you to the chat that Mark has posted some really interesting stroke trials that are ongoing in Telerehab. So do have a look at those. I actually do, like, I was just thinking, wow, I saw someone yesterday and I feel like they would be really great for a V-PACE. So I think I will send it to them. So have a look at that as well. Dahlia, go ahead.
Hi. Thank you so much for that. It was really interesting. I just wanted to maybe mention, I really like how you did, you know, you looked through and you're right, there is so much out there, and it's really important to understand what these tools do or don't do and what they may allow to do. And I have some other projects where we're looking at other technologies used in rehabilitation, including that allow remote monitoring and not. So I may be in touch with you guys to have my students follow up on the methodologies also that you've used, and see if we can apply that for different types of technologies. Just wanted to let you know.
Yeah, thanks, Dahlia. That would be great. And Kiran, Kiran, thanks for everything. Is there anything that you wanted to add?
There were a few other devices that I found during the scan, and I just would share my screen. Second here. And one interesting experience that I had was when I was reaching out to Tala specifically, is that they were open to sharing information and collaborating, but noted that some of the information might be considered as competitive information. So depending on the nature of our request, we might need to sign an NDA. So I thought that piece was very interesting, and I will share my screen now. Oh. Or maybe I can just put it in the chat. The list of other devices that were identified during the scan, but not reviewed further in detail. But there are many out there in terms of fall detection, especially.
Thanks so much, Kiran. Much appreciated. Any other questions, comments, things that you've seen your patients use that have been helpful? Dahlia, go ahead.
So we have a student that recently finished her master's. She didn't look again specifically at remote monitoring tools, but she looked at these technologies used at home in rehabilitation and what factors affect their usability. And there's some really interesting things in terms of the technology may allow you to do certain things, but if the person is not going to use it or use it as designed, then it's not going to have the usefulness or effectiveness that you intend to have. So maybe I can share the link to her master's at the moment. I'll put that in, and
when her article is published, I'll share that because the master's is in French, but you can translate it. But it has interesting concepts to consider when using these technologies remotely.
Yeah. Thank you. That would be so great. It's always nice to be able to share resources and things that people are working on. I always like learn something new and interesting from our group.
If there are no more other questions, maybe we should just give people a sneak peek at where we're thinking of for our next COP.
Yes, for sure. Let me just bring up our slides one more time. Sure. Oh gosh. Tech issues. Yes, so I think my screen's frozen. Yep. We are looking forward. By the way, I put this link in the chat. Because we always want to know what you think of the sessions, what you liked, and anything we can do to improve. So that's in the chat, or you can scan this QR code. And then so we'll break for this summer, but keep in mind, we are a community who's always, here. We always want to come together. If anyone's working on anything, you can send it to Meiqi and I. Keep in mind, we've also got our directory, so you can link directly with people of things that you're working on. So we'll stay connected, but we'll plan to have our next formal session in September. And we've got a few of our awesome leaders from rural and remote communities who are going to form an expert panel to talk about their experiences providing telerehab in their communities. So I'm super, super excited for that. And so just to kind of tease, as soon as we've locked in a date, we'll put out a hold just so that everyone can get it in their calendars because we know how busy everybody is. But yeah, otherwise, we just want to say thanks so much for all of your attending, and to Mark and Tharshini again for your presentation as well.
Thank you so much, everybody. May all your favorite sports teams win in the playoffs.
That's a
Go
loaded
Raps, go.
comment. Bye.
That's why I said your favorite. I did not name any specific